Okay, so why don't you just take a minute and just tell us what you've been doing the last 5, 10 years and just a little bit about yourself, just so everyone could hear your voice. Dr. Kahn, why don't you start, then Dr. Katz.
Sure. If you say last 10 years, 10 years ago, I was in a standard cardiology practice, a good one in suburban Detroit, doing a lot of cath lab procedures, but I had already commenced to exit by going back and doing a lot of courses and training and certifications in nutrition and integrative medicine. Learned what social media was, kind of self-taught, bumbled my way through that. Dr. Katz is the master of writing blogs, but I learned how to write blogs and do videos and all. And just to wrap up, about 8.5 years ago, I opened my own clinic. I was told this wasn't going to work in Detroit to take extra time with patients. Everybody's kind of got a blue collar mentality here, the land of the UAW. It wasn't Santa Monica. But anyways, it's turned out to be the most fascinating, wonderful. I love my patients. I would hope that most of them would say the same about me. They get, TLC, they're school teachers and bus drivers and CEOs of multi-billion-dollar companies. Doesn't matter. We do it, it's kind of, the word holistic makes me chuckle because I probably do the most advanced cardiac imaging and lab work consistent with the literature. Serve on, the boards of a few companies that are at the cutting edge. So it's a really nice hybrid. And, just for today, I think Dr. Katz will appreciate this more in the audience. I saw a woman who 5 years ago, out of town, because I have licenses in about 20 states now, had a heart attack, but she had a distinctly unusual heart attack called SCADS, spontaneous coronary artery dissection. And she also had these weird abnormalities of her blood vessels, which is called fibromuscular dysplasia. I had never seen a person that had two unusual vascular, probably genetic, but we don't know the genetic anomalies in one person. It turns out there is literature that they coexist. So I learned something new today. I mean, I'm talking to her and I'm reading and I'm online and expanding my brain power and wondering about what's the genome here. And I co-manage her with the Mayo Clinic, so God knows she's got other good care. But I'm fired up to keep going for a long time, as long as the health stays good, which it is very good at this point, thank goodness.
Thank you. Dr. Katz?
Good stuff, Joel. Yeah, it's amazing, Steve. Thinking about your question, a lot happens in a decade. Goes by in the blink of an eye in some ways, but as I reflect back, so 10 years ago, I was president of the American College of Life, directing Yale's Prevention Research Center. I was still seeing patients, although nearing the end of a 30-year run. I had not yet founded the True Health Initiative, but I was on the brink of doing that. And that was in some ways an effort to translate the presidency of the American College of Lifestyle Medicine into something longitudinal. And I knew I had been president-elect, and then I was president, and then I'd be immediate past president, and then yesterday's news. And I really wanted it to matter more than that. And the True Health Initiative, we can talk more about, but it's a global coalition of diverse experts coming together to say, we agree about the fundamentals of a health promoting diet. We agree about the fundamentals of a health promoting lifestyle. We agree that this is actionable and everybody deserves to know it. And we agree that we can do a certain set of things that are good for people and the planet. And we can thus chase the dream of being healthy, vital people on a healthy, vital planet. So that was established in 2015. And then for the several years after that, I was running the nonprofit. I was managing my lab, the Prevention Research Center, winding down my patient care. But a lot has changed within that decade. In 2016, February of 2016, I think my son knows the exact date, I pretty much had one of those wonderful things in science, an epiphany. I was working out at the time, I was on my elliptical, and an entirely new way to assess diet unfolded in my mind like origami in reverse. And folks in the audience may or may not know, but this has been something of a holy grail. There have been millions of dollars allocated year after year by the NIH and the Gates Foundation for fundamentally simpler, reliable, valid, scalable ways to determine what people are eating. and just had this idea. And the idea evolved, and then I ran it by esteemed colleagues to get a reality check. And make a long story short, I had to form a company to get this concept to daylight. It's now a patented innovation with multiple peer-reviewed publications and deployed to tens of thousands of people. And in 2019, after spending my entire career there, I left academic medicine to be a full-time entrepreneur. I was CEO of this company. We were acquired last year by a large food as medicine company. So I work primarily now in the private sector, which is a radical transition for me, but the mission remains the same. I really sought to do everything I could over the course of my career to add years to lives, add life to years, and to help us achieve what I think we all want, which is a population of healthy, vital people on a healthy, vital planet. We certainly want that when the population is our population, the people we know and the people we love. So different means, same ends, and here I am today.
Great. Okay. So ideally, I would like to, since we only have a short time, ask lots and lots of questions. So feel free on these questions to give short answers. I know in each one there's a lot to be said, but to cover lots and lots of topics, we'll have to settle for the moment for just short answers if that's possible. So here we go. Okay. So if someone just wants to get started, they're in their 50s, 60s, what are the essential medical tests that everyone should consider getting regularly to ensure optimal health and early detection of potential health issues? And either of you can answer that or both.
I'll jump in with a cardiology spin, and Dr. Katz can take it beyond that if he wants. We have something called the U.S. Preventive Task Force that determines and kind of dictates to primary care docs what that list is. And that gets picked up by insurance companies as what's payable. Unfortunately, there's a big gap there. And the biggest gap in my mind is there's cancer screening. There's no heart screening, with the exception of checking a blood pressure and a few very simple lab tests. So, we've had since 1990 a $100 test called a coronary artery calcium CT scan. It's almost perfect. It's not perfect. It doesn't show soft plaque. It doesn't show percent narrowing in arteries. But it takes a 48-year-old or a 54-year-old whose father had bypass surgery, or whose brother had a stent, or has a very high cholesterol or blood pressure, and it directly looks at heart artery anatomy and gives some feedback by something called a coronary artery calcium score. And it takes about 5 seconds. It involves a very low dose of radiation, like a mammogram. There's no injection. And unfortunately, despite the first publication in 1990 and 34 years later, it is rarely ordered by cardiologists and internists and family doctors and gynecologists. I'd say under 5% of people, know their coronary artery calcium score. And it has now been, validated, thousands of studies, that it massively reassigns people, sometimes good news, lower risk, sometimes bad news, much higher risk than their lab work and their general profile. So everybody listening should know one number, their coronary artery calcium score. Now, at some point in this hour and a quarter, we may have time to ask what's new, because that's 1990, but it's a horrible deficit. And just the other part of the equation, it's not completely evidence-based, but there are some lab tests that should be done. The National Lipid Association, a pretty well-known organization, just published last week that everybody should know a blood test called their lipoprotein(a), a genetic cholesterol, something I've drawn in 12, 15,000 patients. Makes a huge difference in management and risk. But it's a $30 blood test that has a billing code, so it's usually covered by insurance. I like to see an inflammation test, high sensitivity C-reactive protein. I like to see a homocysteine level, something called methylation. You can do a lot more, but if you do what the primary care doc does, and you throw on these 3-4 extra tests and the heart imaging study, you've massively personalized and made more precise your assessment of that patient's risk. What diet, what medication, what supplements, what fitness, what reassurance, or what worry they need. So that's my list. And God knows I wrote a book on that topic years ago, and I republished it. And we've seen, sadly, only very small incremental advancement.
Thank you.
And just to append quickly, so great stuff on the cardiac side. You mentioned in passing mammography, Joel, and obviously for women in that age group, I think you said 50 something, Steve, mammography would be indicated. Actually, there are recommendations now to lower the threshold down to 40. For women with dense breasts, that would be supplemented or replaced with ultrasound because mammography tends to be insensitive in women with dense breasts. That's a pretty prevalent condition. Colonoscopy is recommended at age 50 and sometimes younger. And I agree with Joel, an excellent resource for all of you. You can check this out and you can basically look at guidelines that are gender and age specific, courtesy of the U.S. Preventive Services Task Force. You can all Google USPSTF. And then you can see what the guidelines are for you. And as Joel says, these recommendations might be somewhat minimalistic because the bar for evidence for the USPSTF is set extremely high. So they only give an A or a B recommendation. They give letter grades to the various screening programs and counseling and immunizations. They only give the highest grades if there are lots of randomized controlled trials, meta-analyses supporting a practice. And that's a pretty elusive standard. Often what we have is not evidence of absence. In other words, we don't have evidence that something doesn't work, but we have a relative absence of evidence, and then the USPSTF can't reach a conclusion. But for the foundation, it's a great place to start, and it covers cardiovascular screening and counseling and mental health and substance, cancer screening, and immunization. So a whole host of things that are useful in preventing disease. Good place to start. And then, Joel, you took us in the direction, I think, of going beyond population level screening, where we would recommend particular tests to absolutely everybody knowing nothing about their health. And then we would start to layer on additional recommendations once we knew you. And so, if somebody has heart disease in the family and we're not finding evidence of that in the standard risk factors, you might dive deeper. You might do a more involved lipid panel. You might look for atypical risk markers. You might want other inflammatory cytokines. And on it goes. And similarly in other areas where the testing for vulnerability and risk could extend to genetic markers like the BRCA genes that are associated with breast and other cancers. So at some point, we leave the realm where this is recommended for everybody just because of age and sex, and we get further into the realm of we need to know something about you. And if there are indications that you have other potential vulnerabilities, then the testing goes on and on. So, Steve, it's not a one-size-fits-all list, but the U.S. Preventive Services Task Force is a great place to get the fundamentals right.
Thank you.